We bring together some of the most incredible change makers we can find who are leading deep and lasting community-based work around the globe. Today, we're talking healthcare. Yes, we're going to discuss COVID, but we'll also take a broader look at healthcare in America, how we got here, what are we learning from this moment, and what can we do moving forward. This is a very big topic. Luckily, we have a panel of true healthcare leaders here to provide their perspectives and expertise. We're in a unique time. We're in the midst of a pandemic, a recession, a national and much too delayed discussion on equity. The challenges of this moment are very real. But I believe so are the opportunities. Not opportunities to get back to normal. Normal is what got us here in the first place. Rather, we have an opportunity to build a new normal, a better normal that moves us forward to a more just and equitable society. And that's what I hope to talk about today. So let's dig in. I couldn't be more excited about the incredible collection of leaders we have with us. Not only do they represent the very best in their fields, they're also genuinely good people who I have the distinct pleasure of calling friends. Let's get to know them a little bit better. We'll start with Celso Baez III, Government Relations Manager at Central Health in Austin, Texas. Mr. Baez, welcome. Tell us a little bit about Central Health.
Thanks, Michael. Inspiring welcome. Appreciate the invitation. Pleasure to be here with such esteemed panelists. Again, my name is Celso Baez from Austin, Texas, Hook'em Horns. I have the privilege of serving as Government Relations Manager at Central Health, and we are a healthcare district that serves the uninsured, underinsured, and indigent here in Travis County in Austin, Texas. And my role is to look at all the regulatory policy frameworks that could change, are changing, are evolving in our landscape to help folks and to provide high quality healthcare for folks in our area.
Thank you so much, Mr. Baez. Really excited to hear from you today. Next, we have Dr. Leviers, President-elect of the American Academy of Pediatrics and the Medical Director of Community Health and Advocacy at Children's National. Dr. Baez, first and foremost, congrats on your election. Tell us a little bit more about that role and your work at Children's, if you will.
Oh, absolutely. Thank you. And again, I'd like to just echo the thanks for having us all here today. This is a terrific panel to be with, and it's really exciting to be here. So I'm just incredibly honored to have this opportunity to be President-elect of the American Academy of Pediatrics. The AP is an organization of over 67,000 pediatricians who are dedicated to the optimal physical, mental, and social health and well-being of all infants, children, and adolescents. So, it's an amazing opportunity to be doing this and be doing it at this important time. So I've spent the past year on our board, and in January we'll assume the role as president of the AAP and really focus on standing up for children's families and pediatricians through our work in policy, education, and advocacy. And one of the things I'm really excited about is being able to bring my experiences here in Washington, D.C., working with our Child Health Advocacy Institute to that role, where, here I've really been focusing in on increasing access to quality mental health care for all children across DC, really focusing in on supporting families so that they can have the best opportunities starting at the earliest times in their life. So I'm just delighted to be here, and thank you for the invitation.
Thank you, and lots to unpack, and we're excited about it. Dr. Ryan Bosch is next, founder of Socially Determined and a partner physician at Executive Healthcare Services. Dr. Bosch, welcome. Can you tell us a little bit about what Socially Determined is?
Thank you, Michael. Again, it's great to be among friends here, and as a lifelong learner to see so many mentors on the screen here. I'm fortunate as an internal medicine physician, my career has moved through academics, military, also in the consulting world, and to ultimately founding the company Socially Determined. I feel very fortunate in that time that it's really focused mainly on health, not necessarily health care, but the specific needs around health. Socially Determined is a company I founded 4 years ago. We're a social risk analytics company, and we specifically focus on quantifying the impacts of social risk on the marketplace, specifically health systems, pharma, and payers. It couldn't be more important work given the sentiments in this past year, the pandemic, the social unrest. Our work matters, and it's important. I'm fortunate enough as well to work with two partners and still be actively practicing, albeit very small. Board certified in internal medicine. My two partners do most of the work, but it's important for me to be there and be involved. Thank you for having me, Michael.
Excellent. Thank you, Dr. Bosch. Next, we have Kimberly Russo, the Chief Executive Officer of the George Washington University Hospital in Washington, D.C. Ms. Russo, tell us a little bit about GW and UHS and some of the new initiatives you have going in the city.
Great. Thank you, Michael. And again, it's an honor to be here with so many familiar friends and faces and mentors as well. So thank you for pulling this together. So I'm Kim Russo, as Michael said, and I'm humbled to serve as the CEO and Managing Director of GW Hospital. And GW Hospital continues to be proud to serve as a healthcare pillar in our nation's capital and has done that in the metropolitan region for decades. In 1997, Universal Health Services acquired 80% stake of the hospital and has continued to invest in the community and move forward in advancing healthcare within the DC region. Most recently, I think the collective commitment of the GW medical enterprise to lean into the healthcare needs as it was relevant with the COVID-19 pandemic has really been another testament of our commitment to advancing healthcare and servicing our community. But even most recently, we were proud to announce that Universal Health Services entered into a public-private partnership with the DC government to build a new hospital and develop and operate a hospital and ambulatory center that's going to expand and create new services east of the Anacostia River, which, as many of you know, is one of the poorest, most underserved communities in our nation's capital. So we're extremely proud that has become a reality for us, and that we continue to work on really closing the equity gap that exists around healthcare. Thank you.
Thank you, Ms. Russo. Next, we have Mr. Reynard Ware, Vice President of Operations of HCA Palms at Pasadena Hospital in St. Petersburg, Florida. Mr. Ware, welcome. Tell us a little bit about HCA and your hospital in St. Petersburg.
Thank you for having me, Michael. As mentioned, I'm Ray Ware, Vice President of Operations at Palms of Pasadena Hospital in St. Petersburg, Florida, which is an HCA affiliated facility. Just a little bit about HCA. It's one of the largest for-profit healthcare systems in the U.S. Across 20 states, and also assets in London. HCA really prides itself on two kind of overarching themes, which is, scaling best practices and increasing speed to market to serve the patient populations in all of these states and communities. In terms of Palms of Pasadena Hospital, we're licensed at 307 beds and really looking at and focusing on ER operations, OR operations, and really providing the best care possible to the community right here in our backyard, but also people who travel in the snowbirds to come down to provide care on the beach as well. So we're excited to, serve these populations of people, and we look to continue to move forward and advance the care for all people.
Thank you, Mr. Ware. If we can get to it a little bit later in the discussion, you have one of the most fascinating entry into healthcare executive stories I've ever heard about turning an ER visit into a passion that has resulted in you being a hospital administrator. So maybe we can get that a little bit later, but thank you so much for explaining a little bit about your role down in St. Petersburg. And last and certainly not least, we have Dr. John Skip Williams. Dr. Williams, I've known you in so many different roles over the year. You were President Emeritus of SUNY Downstate Health Sciences University. You were Dean at GW Medical School. You currently hold the Dean Emeritus title. And I know there are so many different things you're involved in. Talk to us about what you're currently focused on and just kind of set the stage for us.
Okay. I'm very pleased to be here as well and to see so many good friends. And for those of you who don't know, Reynard Ware was one of my master's students at Georgetown just a few years ago. Currently, I'm involved in mostly food insecurity and providing medically tailored meals to our most vulnerable population through Food and Friends, where I'm the president of the board. We have lots of food deserts, unfortunately, in Washington, D.C. And so we're working to see how we can get the large groceries and distributors to be located in those areas of the city that they're not currently located in. And just as important is those patients that have cancer, HIV/AIDS, diabetes. We provide medically tailored meals. We will serve about 1.2 million meals this year in the district, Maryland and Virginia. My second full-time job is we just opened a brand new medical school in New Jersey, Hackensack Meridian School of Medicine, and I'm the chair of the Board of Regents of that brand new medical school. And we're about to graduate our first class this coming May, and I'm very, very excited about that.
That is fantastic, Dr. Williams. Thank you all so much for being here. I think you can understand why we've assembled such a dynamic panel. This discussion can go lots of different ways, and we're going to do our best to cover as much ground as we can in the next hour. So just to set the stage for our viewers, we're going to talk a little bit first about how we got here. We're going to spend some time on what we're seeing currently, and we're going to try and focus a lot of our discussion on where we're going and what the path forward looks like. So let's start with how we got here. We're in this jarring moment where on one hand, we're seeing the absolute heroics of frontline healthcare workers being celebrated. We're seeing the promise of vaccines and a renewed interest in public health. Then on the other hand, we're seeing glaring systemic inequities and antiquated public health infrastructure, basic facts becoming political, and an overall lack of health literacy and access that's impacting some groups significantly more than others. So I'd love to kind of root our discussion in your experience, in your vast careers. What are some of the factors and forces at work that you think have contributed to this moment? And Dr. Williams, I'd like to continue with you.
Okay. Unfortunately, I'd like to say I'm surprised at what's going on, but I'm not. We have had scientists, we've had healthcare professionals, philosophers, educators have all pointed and said this was going to happen. And unfortunately, we did not listen. And you can talk about systemic racism. You can talk about climate change. You can talk about the healthcare crisis. How does the richest country in the world have some of the worst health statistics in the world? When we have first-class hospitals, but patients cannot afford to go there, or they're in areas of the city where those patients have no transportation. So unfortunately, as I said, we knew this was coming. And now the job that we have to do is to begin to be honest with ourselves. I always say you have to pick up the mirror and look in the mirror, ask yourself the question, and tell yourself the truth.
Such a great point. Dr. Baez, would you like to build on that?
Yeah, absolutely. And I 100% agree with Dr. Williams, right? Our systems are working the way they were designed to. And what we're seeing now is the unfortunate result of that. With my lens, of course, as a pediatrician, I also really particularly think about children and families. And I think we just have had decades and decades, if not centuries, honestly, of underinvestment in children and families. Our focus in medical care is really on the treatment of chronic illness rather than prevention and health promotion. And when we layer those things on top of, as Dr. Williams was saying, these systems of widespread structural inequities and structural racism, which don't involve family or community voice or input, then unfortunately this is where we are. I think to me, one of the things that just is so important is really just thinking about how we put children and families at the center of what we're doing as we move forward.
You talked, that was a really powerful statement. You said systems work the way they're designed. So you really get into the systemic level of our issues. And I'd actually love to go to you next, Dr. Bosch, because as I understand it, so much of the social determinants field is looking at how do we understand those systems and how do we address some of those factors at kind of their root causes.
That's right, Michael. I think it's remarkable in a painful way how the intersection of the pandemic and the social unrest really underscored how health care is what we have, but health is what we need. And so to be proactive and to be aware of the social clinical influence on individuals, their opportunity for good housing, their economic well-being, their housing, their transportation, even health literacy, these things are more impactful to health than genetics and traditional clinical risk factors. So with what we've seen in terms of inequities in healthcare, on top of our public health infrastructure being so challenged, we've not been able to be proactive for the past decade or more, and we're paying the price right now for that.
I want to pivot over to a couple of our hospital execs, because you have such a unique perspective on kind of how we got here and what we're seeing. So Ms. Russo, let's go to you next. What do you think some of the factors are that have kind of led us to this moment?
Yeah, I agree with many of the statements of the other panelists. I mean, to build upon what Skip was saying, as it stands today, healthcare in many areas, such as our own Ward 7 and 8, our nation's capital, the healthcare is unacceptable. Many health systems are limited. We in DC have some of the poorest quality outcomes in the country, and it's inequitable. And when we look at it, it's about access, and it's also about the level of quality of care that they get and their living and all these other social determinants that Dr. Bosch was just referencing. I mean, when you look at the limited access to healthcare in the district, DC is in the worst quartile for, you can just name it: breast cancer, prostate cancer, coronary heart disease. The maternal mortality ratio is almost double the national average. And so it's not only the poor health quality, it doesn't end there. You've got within our city these disparities around health outcomes. If you live in certain wards, you're going to live, almost 16 years longer than in another ward that's just down the street or next door. And it comes down to access and equity to healthcare and the delivery system that we've created.
Yeah. Reynard, what are you seeing?
So there's a few things I think about with this question that makes me think about additional questions. So have we historically had transparent systems of care in America? And are we speaking the same language across cultural and generational classes? I think not. There's a huge public distrust between people of color in an American healthcare system. And I think that long-standing historic, relationship between the two has gotten us where we are today. When you're talking about, do your provider listen to you? Are you receiving the care? Are you receiving the perception of the care that you want to receive when you go to a healthcare facility? It's the access there. And I think the fact that over the last 60 years, African-American people and people of color haven't had trust in the system. And I think that moving forward, how do we gain that trust back, right? Yep. So those are the questions that are being asked. And I think the efforts being pushed for having diverse leaders in the field of medicine and diverse leaders to lead some of these organizations can be the conduit to that. And so that's how I'm thinking about this question. But it's multi-layered, right? It's the social determinants, but it's also the leadership and the access, the quality, and how do we bridge that gap and how do we mend that relationship over time?
Yeah. That trust thread too, I want to make sure we keep pulling on that throughout the discussion, because I think as you look at who's going to have access to vaccines, who's going to take the vaccines if they develop, all of this becomes a trust issue at some level. So I want to make sure we keep coming back to that. While we've got you, Mr. Ware, can you, I hit up on it at the beginning, but can you give the short version of I went to the ER and now I'm a healthcare executive, because I think it gets specifically to that through line of trust and what people expect from the system.
Yeah, so born and raised in Washington, D.C. I'm a Calvin Coolidge coat. I went on to Morehouse College in Atlanta, Georgia on a football scholarship. I played cornerback. In one spring practice, I hit a 250-pound fullback head on, damaged the axillary nerve in my shoulder, went to the ER, actually went to Grady, and my wait time was about 4 hours. And I wanted to know, one, who was in charge of the efficiency, and two, being a finance major at Morehouse, I wanted to know who paid my medical bills. And so those two questions made me pursue healthcare further. I went on to do the Blue for Healthcare Leadership Institute. And that was like my first introduction to healthcare, where I learned the intersection between, hospitals, insurance companies, and government. And from there, did a healthcare admin internship in Memphis and started my career as a consultant in Atlanta before going to get my master's at Georgetown, where I met Skip. The rest was history from there.
I appreciate you telling that. I think it's so interesting to figure out kind of what are those moments when you're like, this isn't right, a 4-hour wait, what's causing this? And then actually, I'm going to dedicate my career to doing something about it. It's a great, a great story for folks to really understand. Mr. Baez, if you can wrap us up in this section, you work a lot at the community healthcare level delivery services, right? So what are you seeing as some of the reasons we're kind of in the moment we're in right now?
For sure. There's a lot of wisdom in the room, and I trust this panel over most at this point in the trajectory we're headed in. Dr. Williams earlier mentioned food deserts, and in terms of healthcare deserts, community care, we run a healthcare centers 31, and federally qualified health centers is the home of over 29 million folks in the country across 12,000 rural and urban communities. And, while I'm proud of my Texas Longhorns, I'm not proud of Texas's healthcare strategy and the way we've been covering our folks, or lack thereof. We're hopeful, though. Missouri passed Medicaid expansion, so we're a little hopeful. But what we're seeing on the ground, with the folks that we serve and the intergovernmental sort of collaboration with the city and the public health authority, is we're woefully underfunded, and it's intentional. It's designed that way, as was mentioned. And it's woefully underfunded, and we're seeing the result of that right now.
That makes sense. Thank you, Celso. Let's pivot a little bit. I want to get to the future here in a few minutes, but I want to settle into the moment we're in right now just for a second. We've talked a little bit about the root causes. We've talked a little bit about the ongoing issues. You're all uniquely on the front lines of this pandemic in many, many different ways. I'd love to unpack a little bit what you're seeing. And let me be very clear, not looking to celebrate the problem and certainly not looking to relive the trauma of the past few months. But I do think it's important to get a sense of the issues you're seeing now that can best inform our path forward. Ms. Russo, GW Hospital, as I understand it, was one of the first in the city to set up a mobile testing unit. You were one of the first in a lot. So can you talk a little bit about what you've been seeing in this moment and what we might learn from that?
Absolutely. I think early on in the COVID pandemic, it became very obvious that we were on the cusp of a secondary pandemic, a silent pandemic. And what I mean by that is that we recognized that we needed to reassure the community that seeking medical care when needed remained vitally important and that it was safe. We continue to experience more critically ill patients due to disease progression, simply due to the reluctance to come to the hospital out of the fear of COVID. And what we're seeing is that this is resulting in more mortality, more morbidity, and it's not related to COVID-19. So we launched a Safe, Trusted, Ready campaign to really kind of build that trust of the community. And we've seen some impact. We still have a long way to go as it relates to the community feeling that it's a safe environment, despite all the precautions that we take and the regulations that we follow so diligently. The second thing that I see is through this challenging environment, is I'd be remiss to not mention the level of resilience in our healthcare workers, right? And it's just been phenomenal and just so inspiring to see that resilience. I think that we're in a cusp right now of that resilience being diminished and resulting into burnout and mental health and well-being issues that are going to plague us for a long time. And I think as healthcare leaders, we're really going to have to dig deep and, as Skip said, look in the mirror to figure out how we are going to inspire people to really come into the field of healthcare. And we've got to address this burnout. There's so much burden on the healthcare worker. We're telling them they can't travel right now with the DC regulations. We're telling them, that they have to, isolate from their families if they're on the COVID units. I mean, we just go on and on with the level of burdens on top of the normal life changes that have occurred with this pandemic. So those are the two big issues that I think are top of mind for me.
And those are both huge issues. And Dr. Williams, you've been thinking a lot about this burden on healthcare workers. And the last discussion we had, you almost called it like the PTSD that they're going through with their families. Can I come to you next to expand on that a little bit?
What is really disturbing to me is the fact that I can pick up a journal, any medical journal, and there's always an article, as Kimberly is saying, on burnout, the increased number of suicides among physicians specifically, but it's other healthcare professionals as well. An article just came out last week about critical care fellows and the amount of depression, the rate of depression, and thoughts of suicide. This is becoming an epidemic in itself. Not to mention the position that we have teachers in right now. Do I stay home with my child? Do I send my child to a school where they could possibly pick up the disease, if not get sick themselves, but can bring it back to us as the adults? And so I am extremely concerned about the mental health and behavioral health of our healthcare workers. And when I say healthcare workers, you know, if you talk, and I know Reynard and Kimberly can bear this out, you talk to the people who clean the rooms, the people that serve the food, that changes the beds of the residents that sleep in that hospital. They're going through the exact same thing, and they usually don't have the resources that the professionals do. And that's why I think that the burden of health care and health on them is even higher. And that's something that we have to take a serious look at.
I want to go to Mr. Ware next to see a little bit about what he's seeing. And then Dr. Baez, I want to come to you after that to talk about the impact you're seeing on families, because I'm seeing a through line here from a lot of the work that you've been focusing on as well. Mr. Ware?
Yeah, so what I'm seeing in my hospital and in my market, operationally, how do we keep people safe post-COVID so we don't see a third wave, right? And so we want to increase the duration so that caregivers and providers aren't being exposed. And so right now, there's a huge push on, okay, how are we keeping everybody socially distanced? What does lab operations look like? What's the turnaround times with certain labs? Is there sufficient signage up so that, you know, when a family member sits down, can we clean it right now? Like get right to it, so there's no lead time for any type of, you know, exposure or you know, where someone can touch and expose someone else. So operationally in a hospital, depending on what type of facility you're at, we're trying to grapple with keeping everybody safe and managing the message. Kind of like what Kimberly said, we're open and safe. That's what we're seeing in Florida right now, particularly in my hospital and in my market. And I think that moving forward, there's an opportunity for hospitals to look at opportunities to look at like a micro hospital type of setting where, you know, a lot of your care is being delivered on an outpatient ambulatory care setting instead of your more inpatient side, because I think the public fear is something we're dealing with. And I think hospitals long term, probably from a financial standpoint, won't be in the best position given where we're moving. And so right now we're just trying to we're trying to grapple with the fear of receiving care in the inpatient setting. But I think when you look at some of, you know, the more millennials, we're more health conscious. We like digital, and so we're more proactive about our care. And so how do we plan for that? And I think that's what we're seeing right now. And COVID really kind of accelerated digitally what we're experiencing right now.
Right. So really looking at the operational aspects of running a hospital and what can you do to make that as clean and simple and communicated as clearly as possible, but also looking at service delivery and where people may want to get their care because they're not going to come to a hospital. That's really
Right.
interesting. Dr. Baez, when you think about kind of families and all of the lagging indicators we have right now of what people are experiencing or not that may or may not be showing up in data, what are you seeing in the world you operate in?
No, thank you for that. I mean, and as I think you all might imagine, and as probably most of you are feeling, right? Families are under a huge amount of stress and strain right now. I think there's the stresses of social isolation. There's the worries about the pandemic. There's the economic impact that so many of our families are experiencing, and we've talked about this in other ways too, but just really amplifying the pre-existing economic concerns that many families had, and so there's a tremendous amount of stress on families and children right now. On top of that, we have our children and adolescents, and young adults, their routines are disrupted. Many of them are not able to go to in-person school. For many of those who are going to in-person school, it looks very different for them because the routines are different. And so there's lots of disruption there. And so we're seeing a couple of things. We are seeing, and this worries me greatly, actually, we're seeing huge increases in mental health concerns with our children and adolescents. Not just in numbers of young people who are having mental health concerns, but also in the severity of those concerns. Increases in suicidality, self-injury, admissions to hospitals. It really is quite concerning. And I my fear in this and in that piece is that we really will be that these young people and families will be grappling this for many years ahead. That it's not just a matter of feeling a little lonely, and when we get back to normal, things will resolve. But really, I do think this is going to have impact on children and families for many years ahead, and our mental health system just isn't really prepared to deal with that. I think some of the other things that we're seeing, and this gets back to what some of the other panelists were talking about as well, is we too are seeing decreases in the visits to pediatricians, and what we're then seeing with that. So first of all, that's a wonderful opportunity for pediatricians to touch base with families, to screen for mental health concerns, to make sure that kids are up to date on all of their sort of routine well child care. And when we're not connecting with children and families, we really miss those opportunities to be able to do that. We're also seeing really concerning drops in immunization rates, and that's worrisome, right? Because the last thing we need is a measles outbreak or a pertussis outbreak in the midst of COVID. And so I think, kind of echoing what some of our other panelists have said, getting back in to see the doctor, pediatrician for your well visits is just so important. And like, again, like all the health systems across the country, pediatricians across the country have the innovation we've seen is amazing. That I feel like is such a bright spot. And Mr. Ware, you touched on this too, that I feel like is such a bright spot is that, physicians and medical teams across the country have been so committed to making sure that families and patients get seen and seen safely, that they've done amazing and innovative things to make sure that happens. So I think that's been really exciting as well. And then I think just to close, I just want to echo the concerns that others have raised about the mental health and well-being of the medical workforce. It just is what our current president of the AP has, wrote an article, and she said it's okay not to be okay, and she just had an outpouring of comments from pediatricians across the country saying thank you for saying that, because that's how we've been feeling, and it was so important to have someone validate that it's okay to not be okay right now, because it's hard. Yeah.
I so appreciate that has become a thing that we're talking about here, because I think it's so often not talked about, and it contributes. I also, without casting any sort of judgment in any of these comments, people have experienced the last 7 months very, very differently. It's impacted everyone, but for some folks, it's been a really awful inconvenience where you've had to stay at home and learn how to get your digital devices working. And for other people, it's been, I have to go out and be a grocery store worker or a delivery driver, or I still have to go and get my chemo treatment, or I have to go to dialysis, and you don't have the option to be inconvenienced. You have to be back out there. And it continues to go to these through lines of trust and who has access and who doesn't. Celso, I'd like to go to you next. What are you seeing in this moment, really at that community level as well?
The Health Services and Resource Administration surveys health centers every week, and we're seeing that health centers are lacking and will not have enough PPE, masks, gowns, surgical masks for the next month. And that's just a horrible position to be in, let alone PPE to distribute to our patients. And what we're seeing among our patients is, those are essential staff that are at the grocery stores, at restaurants, building our homes here in Austin as we're continuing to just build. We're seeing an emergence of telehealth, telemed. And so, about 94% of visits conducted were done virtually. And so we're starting to see how that is all kind of getting into the broader picture of how we're delivering healthcare. We're trying to do as much as we can to prevent a twindemic and encouraging folks to get a flu shot, and partnering with local grocery stores and private sector folks to really administer flu shots and get folks tested for COVID if they think they have symptoms. So we're doing drive-through events where we have, get your flu shot. If you think you have symptoms of COVID, go down the street to where we can test you for COVID. We're partnering with the food bank so that you can get your food distribution all at the same time. We're trying to be mindful of our parents and our students who live in multi-generational households, because it's just not ideal for us to tell them, hey, work from home, get on Zoom. Those things aren't just an option for our families that are experiencing a disproportionate effects of this pandemic. It's just not realistic. So we're having to really shift our thinking and work with a lot of folks here locally around equity and social justice to really get their input on, okay, if we want to set up a drive-through flu event or a COVID test event, we can't schedule it at odd hours. Folks are working around the clock. We have to do it early Saturday morning or Saturday evening when folks are done, essential workers are done working. So we really have to be flexible and agile here on the ground, which takes and requires resources.
Right. It takes kind of taking rather inflexible structures and institutions and making them very flexible to the needs of a moment. And that doesn't, the fact that we're still talking PPE, 8 months into this, is a nice indication of how much still has to be done. Dr. Bosch, close us out on this section. What are you seeing in both the social determinants and in your private healthcare practice?
Sure, Michael. Just listening to the descriptions and the experience among everyone here, we're at war. We're at war with this pandemic, and the battles are so many facets, and they touch us in so many levels. As a founder and leader of a social analytics company, what we're seeing is states coming to us and asking for an ability to look at the distribution around social and clinical risk. So, following the analogy, the ability to have supply lines to the battlefield. Early on, those supply lines were reactive and unclear as we scrambled for PPE and ventilators, and are still doing that. But looking forward, and we think about the social susceptibility to COVID and even to influenza, because they're very close. How can we be smarter with our analytics and take a population-based view so that the supply lines actually are thoughtful? It touches every facet of what we described here, from the beginnings that Dr. Williams was mentioning around physician, emotional impact, and the impact of our country's workforce and our entire continuum of Americans. The ability to have some sense of control, to understand what you're at risk for, and to know that we are matching the needs for not just PPE and ventilators, but the needs for where should we be putting screening? Where should we be cognizant of the care that hasn't come in? The care, like Kim was mentioning, where folks are putting off routine care for diabetes and routine care for high blood pressure. And we're going to see a surge in that care that's been postponed. Lastly, summing it all the way up again to that ability to look at analytics around geography and social risk and clinical risk, we're going to have a vaccine that we're going to have to distribute. And we have to look at that from a total equity and total option standpoint. How can we get the trust as well as the effectiveness of that vaccine out to our community? Not just our caregivers, but the communities at risk because of housing that is very neighbor to neighbor, at risk because of certain social, cultural, ethnicity risk. We need to be able to look at this battle and see it as not just a one-time event, but one we've got to prepare for. That's what I hear when I hear all these anecdotes.
That's such a helpful way of summing up a very large discussion. And I'm so glad you took us to vaccines. As you know, LINK, we do communications and community engagement work. That's what we do. And we do it around the country in urban centers and rural centers and everywhere in between. And this discussion around vaccines is the one we're hearing a lot of concern about from local public health directors, often with their one or two staff people trying to take care of massive amounts of population. I was talking to one the other day, and they weren't quoting actual numbers, but the general idea was we've got half our population who is not going to trust this vaccine. And then we have the other half who's going to want it and not have access to it because they're always the last to get everything. And that's shameful, but real, right? That's a public trust in our institutions and our society, combined with a history of why certain populations have very good understandings of why they mistrust certain institutions, combined with the fact that even if we build the trust, the distribution channels might not be there to make sure the folks who need it most get it most. So on that note, I want to pivot us to where we're going and how we do everything we can to make the best out of the horrible time we're in right now, to learn the lessons to create that better, more just, more equitable future. So just to set the stage a little bit, we've talked about how we got here. We've talked about the realities of the moment. I want to spend the rest of our time together really looking forward. Based on what we know now, what do we need to do to create that new and better normal that I know we're all so desperately working towards? Dr. Baez, can I start with you?
No, absolutely. And I appreciate us ending on this because I think, over the past year, we've really seen very, very up close the deficiencies in our health systems and in our other systems. But this is really an opportunity for us to think about the light. And this is really an opportunity for us to think about how we do things better and more equitably. I think, there's probably three key things that come to mind for me. First is really thinking about how do we design our systems such that we're focusing in on the whole patient and the whole family, and that we're resourcing our health systems to do that, and that we're thinking about how our payment models are set up so that we can really provide, that we can provide comprehensive care, integrated care, and in the places where our patients live, work, and play. I think the second piece, and we haven't touched on this as much during this panel and probably haven't given it the attention that it deserves, but we really need to begin to think about racism as a public health issue. That really is at the root of so many of the inequities that we've seen during the pandemic. And we have to start thinking about racism as a public health issue if we are going to make a difference. And I think the third piece is this is part of addressing that is thinking about how do we better partner with, engage, and let our communities and patients lead when it comes to designing better solutions. I think as a health system, we have a tendency to be very insular, and we like to talk to each other, and we pat ourselves on the back for the great ideas that we've come up with, but we really have to design it, and we haven't gotten where we need to go. And so maybe that should be a message to us that we need to walk hand in hand with our communities and with our patients, so that we can design solutions that really meet their needs and think about how we can help them lead those solutions.
Right. I'm so glad you raised all three of those issues, and each of them deserve their own hour. But on that last one, as someone who does a lot of community engagement, it's not a focus group, right? It's not, we're going to ask you the same thing you've been asked for the last 30 years, and then we're going to do what we think is best anyway. It's a feedback loop of, we heard you, and we know we got this wrong before, but please trust us enough to try and get it right the next time. And when we don't, stick with us, because we're going to keep coming back and getting this right. So there's a whole dialogue around it. It encompasses all three of the points. The last Changemaker panel we did was all about equity and really getting into the roots of structural racism, et cetera. And there was an intentionality behind doing the healthcare one next, because you can't talk about these as disconnected. So I so appreciate you giving voice for that in this discussion as well. Dr. Bosch, where are we going?
Michael, I can't help as internal medicine to hear my mentors and hear in my head the phrase, diseases discriminate, you cannot. And that's how I was trained. And that goes back to taking care of the patient first in the patient-centered medical home. We know that social risk matters to health. Notice I didn't say healthcare again, health. And health is a unique and treasured community asset, a community asset. We need to be humble enough and arrogant at the same time to use the power of analytics and the power of listening to our customers. Raymond mentioned earlier that trust matters. If we can't actively listen, we're not going to force solutions on folks. We need to listen. So lastly, I believe the new normal is where, again, in a humble way, we've got to measure our progress. We have to be able to say where we are, whether that's social injustice, diversity and leadership, public health, infrastructure, inadequacies. You just simply cannot change what you cannot measure. So I believe we've got to commit to that process and commit to improving.
Yeah, so well said, Dr. Bosch. And I think I would add an addendum to that once you have the data and you have some of the scientific basis for this, you have to be willing to listen to it. I think we're in this really interesting widening trust gap where nothing is for sure any longer. Everything is up for debate, mask wearing, et cetera. So once we have the data and we factored out all of the systemic things in that data, how do we make sure we listen to it to guide some decisions? Mr. Ware, where do you see this going? How are we creating this better future?
I think Dr. Bosch and Dr. Baez raised some great points. For me, I think we're moving to a space where communication and empathy matters most. I think you guys talked a lot about understanding the emotional aspect that COVID has had on some of our caregivers. But moving forward, how do we as leaders come to the table to better bridge those communication breakdowns and be more empathetic in how we lead, so we can then provide actionable and actionable oriented solutions that cater to all people and not just some people. And so that's where we're moving when we're talking about some of the financial models that looks at prevention, and models that look at, providing some of our Medicare populations with PCP so that they can know to take their meds. And so I think that's where we're moving as a country. And I think there's a ton of opportunity for us as leaders to just be more empathetic and bridge those communication gaps, because I think those are the two large pieces of the puzzle. And if we get that figured out, we'll be in a much better space for improving the overall health of the communities that we serve.
So well said. Ms. Russo, where are we going?
Yeah, well, I think leadership and empathy are going to be extremely important in the future. But I really hope that as we go forward, we focus on advancing, the health to be community-based and just person-centered care, so that we can really eliminate the equities and accessibility and some of the other things that we've all talked about that are experienced by so many. In today's healthcare landscape, it's about partnerships and collaboration and making sure that we are engaging as a community to help build trust and to improve outcomes of health. So I think building a healthier tomorrow is really going to require leadership. It's going to require the engagement of everyone and thinking differently about new technologies, new models, using data analytics to drive decisions with the engagement of the community. They are the key stakeholder here. So simply stated, I think together we can do more and hopefully change to the future of health being community-based.
I'm feeling hopeful in this moment, and that's a great feeling we don't have enough of these days. I'm feeling good. Mr. Baez, don't ruin it. What do you think the future looks like, good sir?
That's a tall order, a tall order. I won't prophesize on the national landscape, but here locally, I'll echo Kimberly's commentary on partnerships and sort of that intergovernmental and political will. You know, when we look, I'm personally proud that in Austin here locally, our city council declared racism as a public health crisis. But that needs to be matched with structural teeth and codified in policy, and budgets need to represent that. With the public health authority, the city budget, our healthcare district budget, that all needs to be reflective of our priorities. And by design here in Texas, we're kind of fragmented. And so we really need to work closely with the school district, the city council, the public health authority, the transportation authority. I'm happy and humbled all the time to work with my peers in those intergovernmental agencies, because we're a growing city here in Austin, arguably the envy of the country. Folks are moving here in droves, and we have to plan for that. We're going to double in population here by 2040. And so we need to really prepare for that so that we don't continue suburbanizing poverty. And that's how we need to plan for transit, how we need to plan for healthcare facilities. And so I couldn't agree more. Leadership, partnership, empathy, and engaging the community. While we have the data, to Michael's point, we've done a lot of engagement together. I've seen Michael lead a ton of engagements across the country. And you know, we may have all the data in the world, but how is it community informed? And how do we treat folks like we're doing things with them and not to them? I think that will be key moving forward.
In our last panel discussion, we had Dr. Burnett from Houston-Tillotson University, great HBCU in Austin, and she was expanding on a lot of those partnership needs as well. So I know you're already working with her, but there's such great connectivity happening across sectors, which is just awesome to see. Dr. Williams, where are we going, sir?
Well, I happen to agree with everything that the other panelists have said, and I would just like to add honesty. When I said look in the mirror, I really meant that. Right now, if you were to query most residents in hospitals right now about pain, they would tell you that Black and brown people have a higher pain tolerance, and that's why they get less pain medication in the ER. That's bull. An article came out last week, and I don't know if Dr. Beers has seen this yet, where it showed that Black babies, you have a copy of that article, die more frequently when treated by white doctors. Why is that? We have to be honest enough to go into our educational institutions, whether it be nursing school, therapy school, whether it be hospital administrators, medicine. We have to put this on the table and be honest. There is systemic racism. We all have biases, and that's okay if you understand it and where those biases are coming from. We cannot be afraid to bring up these issues anymore, because it is truly, as we're seeing, life and death. None of us on this panel is surprised that Black and brown people are suffering disproportionately. We should be shocked, but we're not. Mm-hmm. And so I would argue for honesty.
That is so well said. There, that article that you sent me, and I read all of it, and then I posted it. And I had a woman who I grew up with, a woman kind of helped raise me, she wrote back immediately, "You make everything about race. Doctors don't go into medicine to be racist. Please unfriend me." And it was that moment of like, nope, let's dig into this. And so then we spent the next 3 days going back and forth on posts about what systemic racism is. Who knows if I converted one person or not, but everyone else reading that now got into a much deeper discussion of what systemic racism is. And sometimes I think that's part of looking in the mirror. It's not doing the easy stuff of I'm unfriending you, I'm unfollowing you. It's like, let's get into some of the stuff I didn't know before I studied it, and let's talk about this and make some progress. So I so appreciate you kind of holding us to that standard of honesty and forward movement. I want to end us here today with a call to action. We're all going to turn off the screen after the panel. All the folks watching are going to go on, and life's going to come at us fast. And we're all going to have just a moment to remember something from this great hour-long discussion to take into the work we're doing. So for the folks that are watching us in healthcare, but also for the folks who aren't, what is that one tangible call to action you want to leave us with as we wrap up today? Dr. Bosch?
That call to action, Michael, that just resonates with me is be an active listener, especially over the years of being experienced in healthcare and with the esteemed colleagues I'm here with and have learned from. Just listening. Listen to the communities, listen to the persons and patients and members. Social risk and medical risk are intertwined, and we've seen that throughout the course of 2020. So this panel and my charge would be an active listener and a voice for change.
Thank you so much. Mr. Ware, your call to action, sir.
Dr. Bosch took my thunder. So my call to action would be to not only listen, but to understand and be empathetic in your quest to understand and take a step back to put yourself in someone else's shoes. And I think that's really how we're going to push the needle forward and make some substantial change and improving patient populations for years to come.
That's great, Mr. Ware. Thank you so much. Mr. Baez.
I'll be excruciatingly brief here. My call to action is to vote. Thank you, Michael. And thank you.
I love that. I love that. I'm going to go to Dr. Beers next, and I see your vote sticker behind you. This is good.
Exactly. Well, I was going to say, Mr. Baez stole my thunder. I was going to say about, I'll add to that. In the AAP American Academy of Pediatrics, we have a phrase, vote kids. And it means take a moment to learn about what your policymakers, what the impacts of their policies are on children and families and communities, and learn about that when you make your decision to vote. So I'll add to that, vote kids.
Love that. Ms. Russo, call to action.
My call to action is be kind and a responsible community member.
Yes, yes, absolutely. Dr. Williams, we started with you an hour ago and we're going to end with you. Call to action, my friend.
I won't be as short as Mr. Baez. Get involved. We have wonderful, wonderful organizations out there, and get involved.
Thank you all so much. I can't tell you what it means to me and all the folks watching that you take time out of just incredibly busy days to have this dialogue. I think this dialogue is going to start a lot of additional dialogues, and that's the point of really good discussion. So thank you for being here with us. We'll be back with another Changemakers series going forward. If any of the viewers have topics they'd like us to cover, please let us know. Until then, please be safe, wash your hands, wear a mask, and let's love each other. Thank you all.